here tonight to this Lister lecture. For those of you who don't know the Royal Society, 233 years old, a unique organisation that brings together people from across society in Scotland, academia, business, the professions, and I believe does a remarkable job in its the contribution it makes to the well-being of Scotland, a particular hobby horse of mine. Our lecturer tonight is Dame Sally Davies. Sally qualified in medicine from the University of Manchester in 1972. Later on, she became a consultant haematologist at the Central Middlesex Hospital, where she became a world authority on disorders of haemoglobin, the red blood cells. By 2004, she became Director General of Research and Development in the Health Department in England, and subsequently Chief Scientific Advisor to ministers across the UK. 2010, she became the first woman to be appointed Chief Medical Officer in England, and thereby set a trend, because recently 3 out of the 4 Chief Medical Officers in the Scottish home countries have been women. And indeed in 2013, Radio 4 Women's Hour declared her the 6th most powerful woman in Britain. Knowing Sally well, I can only imagine what the other 5 are like. So it's a great pleasure to welcome her here tonight, and we really look forward to hearing her views on this extremely important issue. So I would now like to invite Sharon Todd, who's Executive Director of SCI, to introduce the SCI and the background to the Lister lecture. And over to you, Sharon.
Thank you, Sir Harry, and good evening, everybody. Welcome to the Lister lecture. Before we start, I'd just like to say thank you to the Royal Society of Edinburgh for hosting us this evening. It's a great pleasure to be here, and we appreciate the hospitality for hosting this event. For those of you who don't know, and I'm sure you all do because you're sitting in the room, this lecture is designed to commemorate Sir Joseph Lister. It was founded by SCI in 1944, so it's quite an old medal and lecture that we're celebrating this evening. And for those of you who don't know us, SCI is actually called the Society of Chemical Industry. We've abbreviated our name to SCI, and we were established in 1881 by a bunch of quite maverick scientists, inventors, and entrepreneurs. Our whole objective is to promote the application of science into industry, and our founder members were an eclectic mix of people such as William Lever, who went on to establish Lever Brothers. We had members of both the Procter & Gamble families from the northeast of England, who then went off to the States and established P&G. We had people like Henry Tate of Tate & Lyle, the sugar family, who I'm sure you know very well. Tennant's, a very old Scottish family. And also people from Pilkington's Glass. So a real mix of sort of entrepreneurs who came together really to promote innovation. They were very inspirational because they actually established the society way before there was actually a chemical industry, 30 to 40 years before actually the Industrial Revolution of the 20th century. So we're quite a unique society. We are multi-science. We have a core around chemistry, but we have all types of scientists in our system. We're also multidisciplinary, and we're an open society. So anybody who's interested in innovation and key enablers to innovation, specifically patent lawyers and publishers. And our applications are very broad, from food and agrochemicals to pharmaceuticals and energy. So just moving on to the Lister lecture. It was founded in 1944 to recognise Lister's achievements in medical sciences. It was first awarded to Sir Alexander Fleming for his discovery of penicillin, and it's only been awarded 15 times since 1944. The last award was in 2009 to Professor Hugh Pennington, who I'm sure everybody knows, who gave a lecture on learning lessons is hard, making predictions difficult. I wasn't there myself, but I'm sure it was a fascinating lecture. And tonight's lecture will be the 16th memorial lecture given by Dame Sally. The award, and we're actually going to present the Lister Medal, is to recognise pioneers and influencers who promote good science to tackle global problems, specifically here in the medical field. And I'm sure you'll appreciate alongside with me that Dame Sally is a very good recipient of that. And just to show you some of the names of the other sort of 15 on this list, you can see the other awardees of the Lister Lecture. So without further ado, I'd like to invite up Alan Bayliss, who's chair of our Board of Trustees, to present the medal to Dame Sally and to introduce the lecture.
Okay, well, thank you, Sharon, and thank you, Harry, for those introductions, and good afternoon or good evening, everybody. It's great to see such a packed house for such an important lecture that we're going to have tonight. So this is the SCI Joseph Lister Medal, and I'm very pleased to ask Professor Dame Sally Davies to come up and receive the medal for her work in antimicrobial resistance. So well done, and thank you very much. Okay, so without further ado then, I'm now going to ask Sally to come and give her lecture on antimicrobial resistance and the global problem. So over to you, Sally.
Thank you. Well, let me start by thanking Harry for the introduction, but particularly the SCI, Sharon and Alan, for this honour. It is indeed an honour to be the 16th lecturer, the 16th receiver of that medal that is stunningly beautiful. Yes, I'm a bit overwhelmed. Thank you. And particularly honoured as well that it remembers Joseph Lister, who brought antiseptics into the hospital and pioneered bacteriology back in the late 19th century, which is, of course, the subject of what I'm going to talk about. And you've heard I'm a haematologist. I've had to learn my public health as Chief Medical Officer for England and our representative for the UK government abroad. And I think I woke up to infection when I had to lead a lot of our response to Ebola. And I'm not going to spend a lot of time on this, but it is important to remember that many in public health have been devoting their efforts, and we need to the lifestyle issues and non-communicable diseases. And I think that our global system had forgotten also about the importance of infectious diseases, and Ebola was a great wake-up. But we in this country have always been aware of resistance, and actually it started with that first prize winner of the Lister Medal. He won it in 1944, but he was public in 1945 when he picked up his Nobel Prize about the risks of resistance to antibiotics, and that actually there would be deaths as a result. So it goes back that far. Of course, one of the problems was that people thought that we had cracked infection. And I thought that HIV would be the wake-up call to the world, that we hadn't cracked infection. And then along came antiretrovirals, and it's changed from being a killer most of the time to a chronic disease. And it wasn't helped in 1967 by the Surgeon General telling the Senate that the time has come to close the book on infectious diseases. And we did steadily, over the last 30 years, disinvest across the world in research into the basics of bugs, the distribution of bugs, and the finding of new antibiotics. And before I get into more of that story, let's just consider why it matters. If we don't have effective antibiotics, we will, as I say, lose modern medicine. I try describing to people in the pharmaceutical industry, you know, the big barons of industry who say, well, why should we do antibiotics? And I say, so when I get cancer and the oncologist says to me, well, I can give you chemotherapy and you might get a cure, but you're sure to get an infection but we may not have an antibiotic. What am I going to choose? The horror of chemotherapy and a possible cure from cancer, but death from infection, or my bucket list? And they said, this is a lack of corporate social responsibility that we have disinvested through big pharma in a big way. But it also underpins antibiotics, hip replacements, caesarean sections, organ donations, many things. If I put it into context, 1 in 4 deliveries in England now are by caesarean section. 1 in 2 women in the UK will have a urinary tract infection that needs antibiotics across their lives. And there are 4 million operations a year in England, many of which have antibiotics. Now, I am sloppy, and I want to apologise at the beginning. I slide in between antimicrobial, and there I do mean viruses, bacteria, fungi, you name it, parasites, the lot, and antibiotics where they impact on bacteria. And I do that because I think that while most deaths worldwide relate to TB and malaria resistance or lack of access, our big concern is the rise in resistance to antibacterials. And people have seen this coming, and people like Mark have been talking about this and raising the awareness. And I would argue that we haven't globally taken action because of the complexity. And most people faced with complexity put their heads in the sand. Mark hasn't. I don't want anyone to think anything but wonderful things about him. So we have a problem in humans: overuse, underuse, maluse. We have an issue with aquaculture, fish farming. I'll come back to Scotland and fish farming. I've had a whole postbox about it. But let me tell you, the story I'm told about the States is that by the time you eat a farmed salmon in the States, it has eaten its weight in antibiotics. Yuck. They tip antibiotics in with the feed. So, and one of the things here you see is sewage, and I do want to just highlight environment is part of One Health. The runoff from hospitals that overuse antibiotics, the runoff from farms that overuse it, the runoff from aquaculture, I was going to call it pisciculture, fish farming, and also from factories, if not properly handled, is very, very worrying. We have increased resistance to fungi and insecticides. This is a problem everywhere, and it goes to and fro between the different levels, let alone pets, as the Scottish Chief Vet said in the panel this afternoon, which is a key area. And food animals across the world is a big issue. Antibiotics are used instead of hygiene in many parts of the world for growth promotion and prevention of infection. And we all know that ill animals need treating, but do well animals need treating? Surely we can find ways where well animals don't need treating. And then, I don't know the Scottish data, but 280 million chickens in England every year in the supermarkets have Campylobacter with drug resistance on their skins. You know, if they didn't pick it up in the farm, they pick it up in the abattoirs and everything. So it becomes such a complex issue that when I started looking at this, everyone said to me, what are you going to do? It's just far too complicated. And it's made worse by the fact that there has been no new chemical class of antibiotics since the late 80s coming into routine use. So when I trained, as you heard, in the 70s and 80s, when my patients had resistance, the microbiologist said, don't worry, Sally, we'll just open the cupboard and get out another drug. It'll be fine. And it was. But no longer can we do that. We've just had an outbreak, which we're not on top of fully, in the northeast of England, of resistance to antibiotics of gonorrhea, which is looked after in specialist clinics, and it's spread quite interestingly. You can track where it's spread to across the Pennines and things, and it's very worrying. Gonorrhea without treatment is a very unpleasant disease. So we've got masses of challenges. Are we using antibiotics when people have viral infections? Latest data from the States, 1 in 3 community prescriptions are irrelevant. Are we using them in animals when they're well and they don't need them? One of the issues that came up in this afternoon's panel, more people are dying of lack of access to appropriate antibiotics in the developing world than are dying of resistance at the moment. It's just that we hope we're going through aid and better organisation, strengthening health systems to increase access, but resistance is going up all the time. We have imperfect regulation. Across the world, there's a lot of what's called falsified and counterfeit medicines available in markets and even from chemists, occasionally here in the UK too. And at least 20% of those falsified ones are antibiotics. So people are not only buying antibiotics instead of having them on prescription, they're getting crummy stuff in a lot of places, which perpetrates the resistance and drives resistance. So you could say, we're an island. Why do we care? And it's because it's global. So one of the studies I like is from Sweden, where they looked at the bugs in the gut of young men before they went backpacking. No antibiotic resistance. They looked after a month's backpacking. 25% had resistance in the bugs in their gut. Fine, because they're healthy, they'll eliminate them. But if one of them gets ill for some other reason, those bugs and resistance can get into their bloodstream and infect them and give rise to trouble. So, what do we do about it when clearly we have a market failure for this and we don't have the diagnostics, as was said earlier? And even if we do have the diagnostics, do we know how to put them into practice? So I thought, when I stumbled across how much worse this problem had got in my CMO annual report for England in 2013, that we should do something about this. And so we started and we got a resolution at the WHO the following year. And once we'd raised, with the support of Mark and many others, the level of noise in the UK, I went to the Prime Minister and said, you know what made a difference with climate change? It was Lord Stern looking at it through an economic lens. Please will you commission an economic review? And that was Jim O'Neill, who had been the chief economist at Goldman Sachs, who later became Lord O'Neill, and helpfully is now Minister in the Treasury. He runs the Northern Powerhouse and Commercial Secretary roles. And his final report came out a couple of weeks ago, and I'm going to use some of the infographics that come out of it just because it's easy to explain. And we thought he was going to look at the economic market failure issues. He looked at rather more than that. And he's looked at the fact that we need to improve access, make them more available. This top graphic shows a study from 2012 where 2/3 of the selected antibiotics that were given to patients or prescribed were not available in more than half of the studied countries. So the right antibiotics weren't available in 2/3 of countries. The bottom graphic shows a study from 2015 where nearly half the children and newborns in that sample were treated with suboptimal doses of commonly used antifungals. So just examples of people not getting the right drugs, and even if they do, the wrong doses. And you put that together with the increased use of antibiotics, and we get quite a scary picture. The darker the colour, the greater the consumption of antibiotics over the last decade. And what you'll see is, Jim O'Neill is known as Mr. Bricks. He coined the term BRICS. I should know when, 12 years ago, I think now, but I've forgotten. And what he said was in 2050, if that growth went on, they would make up a significant part of our economy. And it's Brazil, Russia, India, thanks, China and South Africa, thank you. He also coined the term mints afterwards. And what you can see if you look at the BRICS is that they're very red. Now, some people, when they see this data, say, well, they're overusing antibiotics. They are using a lot. The question is, what on? And a lot of this growth in the BRICS is about development, increasing access. The big question is how much is bad use and inappropriate use. And these are issues that we're all having to grapple with, not only in our own country, though you can see we are a bit pink, and I could show you, but I haven't put it in today, data showing the twofold variation in prescribing by GPs in one bit of England as compared with another bit of England, and the outcomes seem to be the same. So we know we've got inappropriate prescribing. One of the things Lord Jim did with his team at the beginning was to say, so how much is this going to cost the world? And he used his BRICS example, and at the moment we have about 8 million deaths a year from cancer. And they calculated, not from looking at all the drug combinations that the WHO is concerned about, but looking at a selected few, that if we don't get some new antibiotics and treatments, by 2050, the death rate will have dramatically increased over it. He did the economic burden too, and I'm not showing you that, but basically by 2050, we would have lost to the global economy, now this sounds silly because it's such a big number, 100 trillion pounds, US dollars, this is all in US dollars. I'll translate that. It's the equivalent of 3.6% of the global economy, the UK's economy as a whole, lost to the world. This is really significant. And he began to look at how there are no borders, and I've chosen 2 bugs here, both Klebsiella with resistance, and just to show you whether you take the orange or the blue one, how quickly they travel round the world. We are an island, but we are not protected. Both of them landed up in the UK pretty quickly. It took 5 years for the orange one and a couple of years for the blue one. And resistance across the world is getting worse. So I'm now going to show you a really busy slide that was made by the Longitude Prize people, and I'll try and explain it. But it's rather nice. So what it starts with is it's showing resistance levels, and the darker the colour of red, the worse it is. Where it's black dots, it's much worse than if it's white dots, as comparing 3 years, 2011 to 14. And you can see the North European countries there, now all of Europe, and we'll start here with E. coli, and you can see the resistance patterns in North Europe. And that's Klebsiella. And you can see how bad it is becoming. It's just a snapshot, but it begins to show it rather well. And another way of looking at it is we have in this country superb surveillance with all our public health agencies working together. And this is looking at carbapenemase producing enterobacteriaceae. And you can see the resistance patterns going up, or prevalence going up year on year. And you can see the different colours show you the type of resistance. And I'm not going, because I'm not particularly strong on this, into the different types, but I'm sure someone can help us out if you want to know more. And recently, you will have heard, and it came up this afternoon, about colistin. So one of the issues about resistance is that the genes in these bugs have a mutation, and that gives them a selective advantage in the presence of an antibiotic. And bacteria multiply about every 20 minutes. So you can see how overnight you can get a dramatically big population survival of the fittest. Unfortunately, that's not the only way of developing resistance and transmitting it. They also have little infective circles of DNA called plasmids that can get little mutations in, and then they stick out kind of channels, arms, to their mates, to their cousins, their aunties, their brothers and sisters, and shoot these plasmids along, giving their mates resistance, and then those mates, when they multiply, pass it through to their progeny. And these are called plasmids. And the real horror of this MCR1 colistin resistance is it is a circular plasmid with the resistance. Colleagues from Wales found it in Chinese pig farms, and this means it can spread horizontally, so it really is a risk. PHE have gone back and looked at historical samples, and we've found a small number of positive samples for this plasmid, and that gene have been present in the UK. And I've just flown back in from the United Nations in New York overnight to here, and lots of people were talking about the case described a couple of weeks ago of a woman in the States who had colistin resistance due to this. And they're all getting really twitched. About time too, I say. But there you go. It's a pity some woman has to suffer for them to wake up to the reality of this. So what can we do about it? And I'm going back to Lord Jim's work. If we can prevent infection and not use antibiotics badly, inappropriately, then clearly we will slow the rise of resistance. So public awareness, sanitation, hygiene, terribly important. Vaccines and alternatives, maybe phage therapy. The Russians tell me it probably won't work, but I look forward in old age to drinking cocktails of phage before I go to hospital. Rapid diagnostics, so you only use them when you know you need them. We need education, and of course we're going to have to look at overuse, whether it's in agriculture and the environment or in humans. So we're going to have to go at all of this and work hard at it. But as Mark pointed out, or someone did this afternoon, we actually don't know the magnitude of the problem. We do for the UK, and we have super surveillance, but there are massive gaps in surveillance, the white areas across the world, and where they're hatched, it's almost as good as nothing, really. And then that is underpinned by actually a lack of diagnostics to look after patients and the One Health arena effectively. So we persuaded the Chancellor to give us £265 million for the Fleming Fund, which is going to be UK-wide. It is to support low-income countries developing their laboratories, diagnostics and capability to diagnose in a One Health manner resistance, or bacteria first and foremost, then resistance, and then provide the surveillance and feed that into the global surveillance system, which is what GLASS is, the WHO Global Surveillance System. We're also going to include in this the development of some people called Fleming Fellows, who may be champions at a senior level or a more junior level in countries to really raise the awareness and work across policy and action, I think I'll call it, to make a difference. So we're just advertising for the managing agent, but we do have a couple of pilots already, one in Vietnam started, and a lot of people across the world are thrilled that we have recognised that we can't pontificate and say to the developing world, you've got to do this, that and the other. We have to help them, and we have to do this in partnership. And we really can make a difference. So I told you on purpose about the US salmon. Well, actually, you can vaccinate every salmon or trout individually with a mixture. I thought it was 3 vaccines. I've just been told it's 4 vaccines. And you can see here the data from Norway that the Norwegians have given me. So I went around talking about this for a year, and then I got a very angry letter from Scottish fish farmers. You're suggesting we don't do the same. We do. I didn't know, but I now make sure that in foreign parts they all know that our Scottish salmon is good to buy, and I make sure I buy Scottish or Norwegian myself. So then I started to look into, so there's a lot of fish farming for tilapia and things in Vietnam and fish farming in Chile. Why are they not using vaccination? And of course, it's because we need to develop the vaccines for the specific infections that different fish get in different water temperatures and everything. But clearly, if we're going to prevent infection and we're going to use less and make this a sustainable system, we are going to have to develop more like Scotland and Norway have done. And that will make a massive difference. And if it can make that much difference there, then it can make a big difference in the rest of animal farming, let alone humans. Flu vaccination reduces antibiotic use dramatically, because if you don't get flu, the incidence of bacterial superinfection on people who've got flu is significantly reduced, so we don't need antibiotics. So it's not only vaccines against bacteria that make a difference, Haemophilus influenza, pneumococcus, but it's actually for flu. So how are we going to work with the global system like Gavi to make sure that these vaccine programs are rolled out in poor countries and that they do better? So I've told you about Jim, Lord Jim, and his report, and we asked him to look at market failure and economic issues. You've gathered he did rather more, and we were rather taken aback when he comes back saying, actually, the most important things are public awareness and rapid diagnostics. So he did a really big piece of work, and his view is we need to reduce demand for antimicrobials, increase the number of effective antimicrobials, and that we will have to do this through an international coalition. I could go into the mechanisms he's recommending, but I'll try and give you just a taste of it. The problem of this so-called market failure is that if the companies, whether they're small or big, make a new antibiotic, they don't recoup their costs, let alone make a profit, from just selling at the price we pay for antibiotics across the world. Two reasons. First of all, we do not pay much for antibiotics. They're very cheap compared with other drugs. So the answer to that would be, well, pay as much as we do for cancer drugs. Actually, even then, it doesn't make economic sense because cancer drugs have recurring cycles, whereas we hope we'll only use the antibiotic in a person once, perhaps for 5, 7 or 10 days. So no one's incentivized to make them because, or develop them because there isn't a profit to be made. So then Jim, from his economic pedestal, surmises, and there's a lot of support for this, what we have to do is what he calls, economists call de-link, and fund the research and development there and separate that from the money you make from selling it. And that's de-linkage. Because, of course, we don't want them to pile them high and sell them cheap. We don't want them marketing because that drives resistance. I want a CMO to lock them up in a cupboard and let them out to save lives. And I don't want them giving to animals. So that is de-linkage. So he has argued that we need to have something called market entry rewards, that when you get to a certain stage where it's come into phase 1, so it's gone into humans and it looks as if it'll probably work, we pay for the development to that stage, market entry reward, and then they undertake, because we've paid that, which is about $1.5 billion, to not sell them high, but to put them into the market in a stewarded, conserved, looked after way. And so that's what he's describing. You then get into, do you pay as a single dollop the market entry reward, or do you do it as milestones, and how do you pay for it? And he's got a number of ways of how you would pay for that market entry reward. I mean, when you come back to it, there are only two payers: us, the taxpayer, or the private sector. And we need to have some way of doing this together. We would argue, Jim and I, that the private sector has a corporate responsibility in this area, or their other drugs won't be needed, and they're making filthy big profits. He's quite interesting coming from the banking arena. He says to them, you know, after bankers, you're the next most filthy lot. And he loves them, really. And we all do. We need them. But the point he's trying to make is you can't fleece the public forever. It's fine making a profit, but actually their profit model's gone if they don't help with antibiotics, because there won't be anything. So his preferred method, and there are all sorts of methods, he describes 3 or 4, is something that has a nickname, at least in the Treasury, called pay or play. So I'll just describe that one, because that's his preferred method, though there are plenty of others, and I have pages that I could read out to you, but it gets a bit heavy, economic theory. Pay or play is basically that the companies either fund doing research in antibiotics, they pay for it. Sorry, no, they play. They either fund the research themselves, then they're playing, or if they're not funding research themselves, they pay a levy, which goes into a fund to pay the market entry rewards, which is called pay. Play or pay. And they've modelled it with a number of people, and they think we can get there. So what do you do about something like that? You give it to the Prime Minister? Do you go home and go to bed and say, I've done my job? No, we've persuaded him to work with us in raising global awareness. That model of Lord Stern doing climate change was he did a report. He then spent a year travelling the world selling the economic disaster of climate change and why people should do something. So Jim has been, well, I've been with him to Brazil, he's been to India, he's been to China about 3 times. We've been all around the world. We're off to the EU in July. We've been in the UN together, all over the world, raising awareness, talking about the issues, showing his economic models. This was not a surprise to anyone. He's talked about the different models with everyone, so it came as no surprise. So we are hoping that the group of 20, the G20, will be discussing economic models, market entry rewards, and set off a piece of work aimed at working up an international system at their meeting September 4-5. I can tell you the government is working overtime on trying to make that happen, and it's looking positive, but we are not certain we will get there. G20 has never considered a health issue before. But Angela Merkel, who chairs G20 next year, has said already that she will follow through and continue work on AMR. So we're hopeful we will get there. So in doing all this international and global work, we have both of us said, but we must keep our own house in order and get it in order. And we have published, a few months after my report in 2013 that got me interested and started me working in this, a truly UK 5-year antimicrobial resistance strategy, which is One Health, looking at human health and social care, looking at livestock, food, retail, veterinary and everything, that has 3 main areas: prevention of infection, preserving the antibiotics we've got, and promoting the better development of antimicrobials diagnostics. And many of you will know about the Longitude Prize, where the public voted for what would it be about, and it is about a new diagnostic, £10 million for a new point-of-care, affordable, that means cheap, diagnostic to help in this area. And of course, we need to underpin this with all sorts of areas, continue the good surveillance, develop it, R&D. Some of you will have noticed a week or so ago the Research Council's launching a £20 million programme of work in the AMR field. There's joint programming of research councils across all of Europe, including some outside Europe in this area. There's a significant amount of new funding coming into this area, and the Wellcome Trust has made it one of their priority areas for going forwards. So it's looking hopeful that we might get to the point where we need to be, which I've clearly missed out, where we've got all of that in place. So the Prime Minister felt that even though we were in purdah for the referendum, that he should make a response to O'Neill. And for England, he has said we will reduce by 2020 bloodstream gram-negative infections by 50%. So we had a debate this afternoon about the value of targets, and they have worked in the health sector before. And he's made a recommendation also for the animal sector. And while this is a broad target that may not work, it has worked in the Netherlands doing it this way, and it is clearly doable. So we can talk more to those issues if people would like. So we've got to move forwards. And it isn't just us in England. It is all sorts of people. And I'm very concerned about every bit. So when I started on this journey, after my annual report in March 2013, I said, we need a resolution. The World Health Organization, experts who'd been at this for years, said, we've had 2 or 3, take you 5 years, won't make any difference. We got it the following year. They said, well, that won't make any difference. And I said, no, it will, because this is starting the process for developing a global action plan. 194 countries signed it the following summer, which was summer 2015, which commits every nation to having their own One Health action plan for their country. And then, having got that, I said, we should go to the UN. We have to take this higher because it is so complex and everyone thinks it's a problem for health. And if you look at governments, health ministries are not powerful ministries. So they weren't going to be able to change it. So here we are with Lord O'Neill saying, it'll cost 40 billion to sort new antibiotics over the next 10 years, 40 billion US dollars. He says that's peanuts compared with what's needed. And in the health sector, we all shudder and say, God, what are we going to forgo in order to do that? He says, but you shouldn't be paying. It's not a lot of money. That is $4 billion worldwide for a new pipeline. This is doable. So we said, all right, we need to go to the UN General Assembly. At which point, the same naysayers said to me, nah, they've done HIV. In fact, there's an HIV follow-up meeting at the moment in New York. And they've done non-communicable diseases, but they don't do health. Anyway, thanks to our Foreign Office, support from our colleagues in the Netherlands and Sweden and many places, we have got a meeting now scheduled for September the 21st in the Heads of State Week at the UN General Assembly. So our Prime Minister will be there, among others. And there's been a lot of work to build to this. In January, about 120 pharma companies made the Davos Declaration that they recognise they have a role in sorting all of this out. The executive board of the WHO, on which I represent the UK, committed to supporting the UN General Assembly week. We went to India in February for a conclave where at the beginning of the week they said, we don't need an AMR strategy. The middle of the week they said, we've got one. And by the end of the week they said, you're damn right, we're going to do a good one. I went to Japan and addressed 18 ministers there on it, and they're all now supporting. The Wellcome Trust ran an excellent summit on the issue. We had a great agriculture meeting where one of the facilitators was the chief vet from the Netherlands, bringing in experts from all around the world on One Health. I've mentioned the Prime Minister's comment at the G7 leaders. There was a very good meeting Monday, Tuesday last week in the Netherlands called the Drive AB Conference, and I've just been with Lord O'Neill in New York briefing the President of the UN General Assembly and various people. So we are going forwards, working really hard. I think we're going to get a significant and worthwhile, ambitious outcome, document out of it, because we're raising the political commitment. But all of this is negotiated by diplomats. It's not negotiated by, I'm not even an expert. There are better experts in the audience. It's not even negotiated by me. The diplomats do it. So when I went to the UN about a year ago and said, I'm expecting you to end up having a meeting and everything, the diplomats said, what for? Why? What's this mean? This time, they're beginning to get it and understand it and why. Getting together in groups and caucuses to discuss what they're going to do and how. And we're getting their own countries, through our ambassadors in their capitals, to push their ministries to tell them what to do. We don't want to supersede the Global Action Plan of the WHO, the FAO, OIE. We want to raise it up and try and get yet more. And there's masses to be done. And it is terrifically important because last year, global leaders came together to sign off the Sustainable Development Goals, the goals that we aim as a global community to achieve across the world by 2030. Number 3, is about health. AMR could destroy people delivering that. But actually, all the other Sustainable Development Goals are underpinned by good health. So we have to sort this to deliver the very ambitious agenda that global leaders signed the global community up to only last year. And I met with the deputy president of the UN General Assembly, who said it better than I've just said it to you. They do get it. And we mustn't rest. We will get a decent outcome. It won't be as good as I want. We all know that. But we can't rest because we've got to change political will into action. And that's going to be very hard. And what we're trying to build in is a reporting back system so that we get everyone signed up now and some action. And in 2 years, they come back and say where they are. And I'll be there saying, well, that's a nice start, but not good enough. Look what the data shows. And really ratchet it up. So that's what we're hoping to do. And we have really good momentum, a lot of hard work, and we're making good progress. So we've all been working extraordinarily hard at this. I seem to spend my life, 60% of my life at the moment, life, work, the difference, I don't have a work-life balance at the moment, is on AMR. I've done the TED Talk, we've got the book. I don't take the royalties from the book, I hasten to add. The other authors, I give the royalties to. But we are doing everything we can as a community interested in this. We've come together to work. We stop pointing fingers. It isn't you. It's we are in this together. We have to find solutions together. Every bit of the system can make improvements, and we need to, because otherwise the death rate will go up. We calculate that at the moment, 1 million people every year are dying of drug-resistant infections, of which 25,000 minimum in the EU, similar numbers in the States, far more in Africa, India, China. Can we stand aside? Can we stand aside and let this get worse when it takes so long to develop antibiotics and face our children and our grandchildren if we don't do this right? Some people clearly think they can. I can't. I'm committed to putting my energy into making the world a better place. And this is one of the ways we have to do it. Thank you very much.
Well, thank you very much, Sally, for that commanding performance around a very, very difficult issue that has the power to really change the world. We've got time for questions. We have a couple of roving microphones here, so if you want to ask a question, put your hand up.
Last week, I was reviewing the Apple App Store to see whether it is an app which will help doctors prescribe antibiotics. And I found one from America which will give you some guidance as to when to prescribe antibiotic, how to do it, but it costs $20. It's not free. I think it will be worth investing in an app, one for healthcare professional, to advise them or give them some guidance about prescribing antibiotic. And we should have another one for member of the public and patients to educate them when to take antibiotic and why not to take it.
An app.
I think that's quite a good idea. I'd prefer you using one based on NICE if you were in England's guidelines, SIGN if you're in Scotland, and I would quite like some games developing for children and people so that they learnt about it. But why don't you go and do one and give it away free? I'm not good enough at it.
Yes.
I've been scratching my head and trying to think about the practicalities of pay or play. Just to give you a couple of examples, right? Even saying what a drug company isn't that obvious. So, for example, AstraZeneca clearly is a drug company. Reckitt and Benckiser, they make Seal It Bang and a bunch of cleaning products, but they've got one or two drugs. How does one, first of all, define who falls within the pay or play domain? And then secondly, what's the basis of payment? So, you know, is it on how big you are? Is it how many people you've got working on antimicrobial R&D? I'm just trying to understand how the details of this might work.
It's a good thing I'm not working it out either. I mean, the discussion will go, are we going to go for market entry rewards? If so, who's going to start to work up the solution? And OECD want to play a role. World Bank are talking about a superbug bond. Various people are. And those are the exact questions they'll have to discuss. But the discussions I've been privy to are about percentage of turnover and things like that as a way of choosing a levy. But the complexity is massive. But the other options produced by the drug companies look as if they'll just make them richer and not solve the problem. And that's no good. Or we just all have to put our hands in our pocket and pay for them, but then hang on a minute, they've got away scot-free. They're still making massive profits on their cancer drugs and not contributing.
Can I ask one follow-up question? Of the 40 billion total estimated cost, or of the 18 billion cost associated with pharmaceutical incentives, what proportion of that would people expect to be made up of pay or play versus, you know, government general taxation revenues?
Pass.
Okay.
Yes.
My name is David Young. You might or might know me, Sally Davies. Years ago, as a student, I remember Michael Swan producing what was then known grandly as the Swan Report, warning in the 1960s, I think it was, about the terrible danger of the excessive use of antibiotics in the agricultural world. You have tremendous forces ranged against you from the pharmaceutical world where they make enormous profits. What control have you got in influencing them just flogging the stuff, which they do in enormous quantities?
Well, personally, I have no control. I just have lots of influence. But the issue is, how do we construct a system which brings in our various regulators and payment systems? Actually, from this country, it's not that difficult because we own the regulator, the MHRA, and we, the governments, whether it's Scottish, England, or wherever, own the health system. So you can construct something. The problem comes when you move into much more complex systems, not even the insurance-based systems, but where they're complex interplays of private and public. And I think they're going to be complex, but, you know, I'm not going to give up. We've got to try and find a way through.
I'm with you.
Thank you. I'm going to need everyone I can.
Just a quick follow-up question about the new antibiotics development. Say 20 years ago, all new drugs were developed by big pharma, the GSKs and AZ, AstraZeneca's of this world. That has changed, however, and currently about 50% of development products are actually discovered by very, very small companies, often 3, 4, 5, 10 people. And I was wondering how you are trying to incentivize those to get this development going. Surely, once they've got a lead compound, they'll have to sell it or license it to a big drug company for further development. But
So there are a number of issues there. I agree that the model has changed from big pharma doing everything to a much more mixed model, working in partnership with academia and very much more small spin-outs. We also have designed into this an AMR innovation fund that Jim thinks needs $2 billion. It'll be US dollars again over 5 years and is included in the 40 billion somehow, but I'm not quite sure where. And so far, our government has put in 50 million and the Chinese government 50 million, and we're just working up the structure for a PPP to try and get other people to put in to help fund the academia, the small ones who I don't think would come into pay or play, so that they can actually do that work. And yes, the model is still you then sell out to a big company that would get the market entry reward. But as long as the system does it, and we're not spending vast amounts of money, then that would be all right. But it's a complex area, isn't it? And the AMR Innovation Fund is going to have a big focus on diagnostics as well.
There's two questions really. The first one is, do you have a feel for which is the biggest problem? Is it human misuse or misuse in farming or in fish farming? And then following up on that is, what was the rationale for the Norwegians to stop using so much antibiotic in their salmon farming? Was that regulatory pressure, or did they do it for business reasons?
I think, but you may know better than me, it was about contamination of the environment and the desire to clean up rather than any other reason why they did it. So the data suggests that human use is the biggest contributor. But we do know we have a reservoir in the food chain relating to agriculture of resistance, and we know there's inappropriate use in the animals, but there's much less data in the animals. There's some tracking data from Canada showing that as you used more antibiotics, you got more resistant bugs, and then you got the same bugs in humans. So there's association data. I don't think we've put enough effort into looking, but I don't think we can wait until we've got all that data. We all need to reduce our inappropriate use, and growth promotion is one of them. But I would argue, till the cows come home, that sick animals need treating.
The O'Neill report suggests, as far as diagnostics are concerned, that by 2028, every antibiotic prescription will be backed up by a diagnostic test result or point-of-care test result. Is that an ambition that you think we should definitely be aiming for? And do you think it's achievable? And because I've been at a few meetings, and that's a response I quite often hear about. People are nervous about that suggestion.
Well, I roared with laughter when I read it, because I'm not sure that we're going to get the innovation in time to get to that position. His point, and I think it's a valid one, is if we don't push in that way, we won't get the innovators believing that there will be financial reward at the end, and that if we push now, it could happen. And I respect that economic model. It's just, hoof, can we really make it stick and happen? But it's a great place to start from.
David Stevenson. Resistance has developed to most modern antimalarials, but quinine remains effective, though possibly a bit nasty. Should we be looking again at things like the sulfonamides that we had before the modern antibiotics?
Another use of the AMR Innovation Fund is to have a look at antibiotics that were used in certain roles and fell out because of toxicity or because there were better drugs, and so that may well be one of them. I think we're going to have to look all over the place for drugs where now, like colistin, the toxicity effectiveness balance has changed. We're going to have to look for new drugs. We're going to have to look for resistance breakers. We're going to have to really scrape the bottom of the barrel to find stuff to keep us going until new drugs come through. But we mustn't lose the focus on preventing infection and reducing inappropriate use either.
Okay, just at the back. Yeah, at the back.
Yep.
Two strands, really. One, you've been quite optimistic, I think, about the global approach to trying to reduce AMR. What are the key measures that are going to be in place to check the ongoing progress? It's question number one. And secondly, if it is very successful and AMR is essentially removed, and therefore very few of the million people that you talked about die, what's the subsequent question about what's going on about the global population and whether there are other issues have to be tackled about the increasing global population?
So we need to develop some data, surveillance, monitoring of sales, and we'll start with imperfect data, and I hope over time improve it. And that's why I want to reporting back in 2 years' time. And in countries, we'll get more in-depth data and show how some data is collectible and is better than other data. And in that way, we can shift the global data collections. The evidence is that with development and education, fertility drops. So that's one of the answers. The other answers relate, of course, to the fact that we are losing productive people, and that if we have young, productive people living, then they will help the economy. And the final part of the answer is, of course, most of us who eat meat are eating too much for our health. And we could really do with a lot of people eating less meat. And then there would be enough for more of the population.
My name's Dr. Caroline Watson. The withdrawal of the tuberculosis vaccine in the United Kingdom. As an individual, I would feel happier being vaccinated against Mycobacterium tuberculosis so that I wouldn't contract it, because if I was unvaccinated, I would hate to contract it and then run the risk of having a resistant bug, and with all the problems that's going to be treated. So I would have thought part of the stewardship would be to maintain whatever vaccination program we have. All right, the herd immunity levels probably are pretty abysmal for TB, but as an individual, I personally would like to be vaccinated. So if I go to some contact tracing for tuberculosis, it's very hard as well. So
I have some sympathy with that, but of course we have a couple of problems. I was looking around for where the experts are. The first is there's a worldwide shortage of the TB vaccine that we have, and the second is it's not terribly effective. So we reserve it for those most at risk. If we had a really effective one, then we should ramp up production and look at using it more widely. But it isn't I don't know, how effective is it? It's not totally effective, is it? Does anyone know?
About 70%.
There we are. And we've got a shortage.
In high-risk groups
yep.
around birth, and that's what's done.
Yep. Thank you.
Okay, I think we've got time for one last question, I think, up at the back.
Just thinking about switching to prevention, are there lessons to be learned to prevent the misuse of disinfectants from the misuse of antibiotics?
Yes, there probably are, but we also need to find new disinfectants, interestingly. It is a whole area I didn't get into and I don't know a lot about, but you are right. Yes, thank you.
Okay. Well, thank you very much for taking those questions. I'd like to hand over now to Sir Kenneth Calman, who will propose the vote of thanks to Dame Sally.
Ladies and gentlemen, I'd like to thank Dame Sally for a splendid exposition of a very complex subject, beautifully described. I came across a phrase recently, understanding complexity, delivering simplicity. And indeed what you've done is taken a very complex problem and delivered it very nicely to us. And can I congratulate you also on the Lister Medal. Lister's always been quite important to me. When I was a medical student in Glasgow, every morning on my way to the anatomy department, I passed a house where he lived, and then into Kelvin Grove Park, where there was a statue of him. In 1965, it was the centenary of the discovery of antiseptic surgery. I was still a medical student at that time, and indeed we helped design a major conference on wound healing around this. So it's always been quite important to me. And James Greenlees, the 11-year-old whose leg had been badly bashed and taken apart and put together again, really quite remarkably by Lister. But there are three other things around Lister which are relevant, I think, to what you said. First of all, he heard about Pasteur from Thomas Anderson, who was professor of chemistry. So the chemists have been important all the time. But I think it's what you described again is going outside the box you happen to be in to another scientific or non-scientific discipline. Secondly, there was a tremendous international effort in this. Not only was Pasteur there, but Semmelweis in Hungary, and the whole thing came together. And your international contacts, I think, have been important. But lastly, of course, there's the action that you have taken, and that was the same with Lister. So you fit very nice into a Lister model. Another person who was writing at the beginning of the 19th century was a chap called von Clausewitz, who wrote a nice little book on war. And I think he describes 4 things you have to do if you want to win a war. First of all, you have to have the political will. And what I thought you described very nicely was just how difficult it's going to be to get that international political will to do something about it. But you're on the way there. Secondly, you have to have a clear strategy. And I thought you were describing that really very nicely, of how we could do it. The third thing you have to have, of course, is people on the ground. So you don't need a big committee at the top. You need to have people who can deliver. And that, I think, you haven't quite got to yet in terms of how we do it. But that's pretty good. And the last thing you need are just a few resources. That might be money, but it might not be money. It could be people who could do it. But what you've done, I think, is shown just how far you've come over the last few years, how far the world has come over the last few years. And this has been a lecture which I think most of us will remember for a very long time. Thank you very much, Steve.